This paper won the Chit Ranawat Award at the Knee Society. And the reason I'm bringing this up, although it related more to the knee arthroplasty literature, it looked at 250 asymptomatic adult young volunteers and found that 32% of the men had 3 degrees of varus, constitutional varus. Really to highlight, when we talk about osteotomy, the restoration of mechanical alignment to neutral may not, in the knee arthroplasty may not be desirable, but also when you're correcting bony deformity, it may not be desirable. And you should have some idea at the outset as to what your targets are and what quote unquote normal is. So my task was to talk about the how and why for distal femoral osteotomy. I'm going to start with the why, really looking at what were we trying to achieve, what pathologies are we aiming to treat, and when to exercise caution. So we talked about anatomy. What are the targets? If you look at the lateral distal femoral angle, the normal MLDFA, according to what you read on average, is 87 degrees. And that's a lateral distal femoral angle as shown in this diagram here. And with respect to the tibia, the medial proximal tibial angle is 87 degrees. So when I talked about, knowing what's normal, if you look at this recent paper by Matt Olivier and his group in Marseille, they looked at neutral alignment. And what they found was that this commonly results from mild tibia vera and mild femoral valgus. And if you look at their data, if you look at the MLDFA, majority of the patients were between 81 and 91, and for the MPTA, between 80 and 90. So it's important to understand that those conflicting deformities exist on either side of the joint to achieve neutral alignment. So with this talk, I'm going to focus typically on coronal malalignment. And if you look at gait mechanics in this patient who's got a varus deformity on the right side, really to highlight here that what does that do? So this patient has an obvious varus thrust. And if you look at him from behind, there's a joint reaction force that's going up down the middle. And as a result of his varus knee, there's an adduction moment due to the medial foot placement. And that adduction moment is counteracted by an equal moment going out from the lateral soft tissues of the knee. That adduction moment has been quoted as being a surrogate measure for medial compartment load. And so therefore you can see with increased varus why you would get a laxity of the lateral soft tissue structures and need increased medial compartment load. The laxity on the lateral side resulting in the varus thrust. So what are we trying to achieve with the DFO? Coronal plane correction, either to reduce the knee adduction moment for a varus knee or the abduction moment for the valgus knee. And the indirect effects would therefore be to reduce medial or lateral compartment load, reduce tension on the soft tissue structures at the apex of the deformity, and eliminate thrust. So quite simply, I like to think of it as a correction of a mechanical issue inside the joint that at least partially originated from outside the joint, i.e. due to a metaphyseal deformity in the affected bone. And that's really what we're trying to treat. So what pathologies are we aiming to treat? So in coronal line correction, osteoarthritis, articular cartilage repair, meniscal transplantation, ligament instability. And what about exercising caution? Firstly, in the predominantly intra-articular deformity, i.e. no metaphyseal deformity, the obese patient, osteoarthritis in other compartments, inflammatory arthritis, my cutoff is age over than 60, osteopenia, smokers, diabetics. So what about the how? This is one of my colleague Matt Olivier's split as to how you go about getting a good DFO done, with the indication being 30% of the job, 20% planning, and 50% the surgery. And within the surgery, we talk about a few different things such as the technique, the correction, the hinge, and fillers. So what have we learned from this understanding of what normal is? Firstly, not all deformities can be addressed at the tibia. Speaking with Matt, who does hundreds of osteotomies a year, I know Dr. Tapasvi is in the audience as well, who does many, the number is 15 to 20 femoral osteotomies compared to the tibia. So there really is key to understanding that not all deformity can be addressed in the tibia. In this particular example, you can see that if you correct all that varus in the tibia, you're going to do a 90-degree opening wedge, and therefore result in a significantly oblique joint line and a very large gap. So If we go on to planning, which is the 30% of the job here, firstly, for a closing wedge DFO, the first thing you want to do is draw the mechanical axis. You then want to establish a virtual weight-bearing axis that's going to go through the center of the knee, really what you're aiming for. Define your hinge point. And I've taken this video from one of my colleagues in Germany, Christian Clay. Really, I think it highlights really well as to what you're trying to achieve when you plan. So for a valgus knee here with the deformities in the femur, really what you want to do is, if you're looking at your hinge and then you're looking at where you want to go, that basically defines the angle that you want to correct. And as you can see here, as I'm rotating from the hinge back to the virtual pointers that I'm aiming for, that really is what you want to correct. And so if you translate that, this is really the Miniachi method. You draw a line connecting the hinge point to the center of the hip. You then do that circular motion that I just showed you on the piece of paper until line A bisects the virtual mechanical axis, and the angle you create is what you want to correct. That then is interposed onto the medial cortex to get a wedge base, which you then measure from a calibrated X-ray. So I want to go through some cases now. So closing wedge DFO is what I showed you in the planning. He is a 32-year-old male. We're talking about the left lower extremity. He had an allograft ACL reconstruction 4 years ago, presented to me with persistent knee instability and lateral knee pain. Talking to him, his bigger issue was the knee pain rather than the instability. He was indicated for a revision ACL reconstruction with allograft tissue by his local doctor. And in terms of the numbers, an MLDFA 84, MPTA 89, and a tibial tunnel 16 millimeters maximum diameter. So I decided to address his deformity first, given the fact that pain was his major issue. In this case, the femur has the majority of the deformity. The two images on the left show bone grafting of his tibial tunnel. And then what you can see here is, after the closing wedge osteotomy, I've shifted his mechanical axis to the center of the knee. And this is, again, a very standard case and a good indication for using the DFO in this setting. You may ask, why did I do a medial closing rather than a lateral opening? In this case, I'm going to go back and do the ACL reconstruction, so I wanted to leave the lateral side of the knee untouched. Another example, this time an opening wedge, 38-year-old female, 2 years of progressive lateral knee pain, now unable to exercise or stand for long hours at work. Occasional mechanical symptoms, but really lateral pain. And if we're talking about the right side here, the MLDFA of 85 MPTA is normal. So in this case, there's an arthroscopic picture there of her lateral compartment. I did a partial lateral meniscectomy and also did an opening wedge DFO. Those x-rays show her knee at approximately 4 months post-op. And then finally, is DFO always done for valgus? So here's a case of one done for a varus knee, and this is where the importance of planning comes in. This patient, left side, varus knee. He had articular cartilage repair as a college student, not clear what he had done. Now age 40, presenting with severe medial knee pain, having failed multiple knee arthroscopies. MLDFA of 91, MPTA is normal. So what we decided to do here is correct his varus through the femur. So I did an osteochondral allograft to resurface the articular surface here, and did a lateral closing wedge DFO to restore his mechanical axis just over to the lateral tibial spine. Just very briefly, double level osteotomies, really to show here in a paper in 2002 by Babis et al. That the acceptable joint line obliquity that a knee tolerates is somewhere between 0 to 4 degrees. So I talked about, trying to do everything through the tibia, for example, in a varus knee. If you look at this patient, medial sided knee pain for 6 years, the joint line axis, the mechanical axis is going way outside the joint. So in this case, if you do your planning, the MLDFA is 92, MPTA is 85. So there is metaphyseal deformities in both your bones. So rather than correcting this all through the tibia, which would give you an MPTA of 100 and require a 21 millimeter opening, not to mention the obliquity of the joint line, if you split it with a femoral and tibial correction, what you can achieve is a neutral mechanical axis, a normal joint line, and a happy patient. My current practice, Dr. Ranawat is going to touch on this. I do all these osteotomies now with 3D planning, with CT, use custom printed guides. A few benefits really for the novice surgeon like myself. This ensures safety, it ensures accuracy. What you can see on this image here is a hinge pin that protects my hinge. And really, Dr. Olivier and his group has shown the reproducibility of this technique. And therefore, it's been a fairly easy decision for me to shift to this technique here. picture showing me doing a medial closing wedge distal femoral osteotomy with, again, my exposure at the bottom, the PSI guide going in, the sort of images I get with the hinge wire protecting me, and then the final product with the plate put in. So the take-home messages: preoperative planning and imaging analysis is critical. Treat the mechanical issue inside the joint by correcting the metaphyseal deformity in the bone that's affected. Not all valgus is treated with a DFO, and not all varus is treated with an HDO. Said differently, femoral metaphyseal deformity can cause varus or valgus. Remain within the normal range of your correction. There are multiple papers out now to show what you should be aiming for: touch of varus in the tibia, touch of valgus on the femur. And if you do have a big correction where the weight-bearing axis is outside the knee or greater than 10 degrees of varus, consider a double level osteotomy. It will respect the joint line.